But thank you, everybody, for having me. As Jamila mentioned, my name's Eric Farbman, and I'm a movement disorder neurologist. So I did a neurology residency like every neurologist does, and then I did extra training in movement disorders, which are any disorders with abnormal movements other than seizures. So the most common thing that I see is Parkinson's disease, but other diseases would be essential tremor, Huntington's disease, Tourette syndrome, and some other rarer things. I moved to Fresno in May. I don't really know where anything is, but I live relatively close to the office, which is, I live on Alluvial, which is like sort of close to the corner of, I don't know, I live somewhere in the medical area there. I think it's kind of close to Clovis because I see the signs change color pretty close to where I am. And so I'm from the Northeast. I grew up in New Jersey and New England and did my residency and fellowship, excuse me, at the University of Pittsburgh. And Pittsburgh was about as far west as I ever thought I would live. And then in 2006, I finished everything. And then in 2006, I moved to Las Vegas. And that was as far west as I ever thought I would live. But so I moved to Las Vegas, and I was in Las Vegas from 2006 until 2022. I was in private practice a little bit, then University of Nevada, which went through some changes. Then Roseman University, which is a small school there. And then I came out here. So I'm with Community Health Partners, Community Neuroscience Institute. Our office is, I have cards, but our office is on North Fresno Street, close to where it intersects First. So surprisingly far from here. I didn't think you could go 15 minutes I thought you could go 15 minutes and get everywhere, and it took me over 20 minutes to get here this morning, so I was a little surprised. I didn't bring any specific slides today. In the future, I'll be happy to talk on topics that people want, but today I just thought I'd come and introduce myself, answer questions. Right now, one of the things that I was hired to do was to do some Parkinson's research. I don't have any trials yet. I'm still getting everything set up. And once things are set up, I'll probably be a member of the Parkinson's Study Group, which is an academic consortium of places trying to end Parkinson's. And there's a lot of clinical trials through it. So with Jamila, Jamila is I never know quite what her title is, but she's like the grand poobah of the Friends of Parkinson's in Las Vegas, which is a support group that was started essentially so that we would not have to divert money to the national organization, so that we could keep it in Las Vegas. And typically there, we have some small things, but a couple of big things each year. We have a big academic, what's the thing called in August? What is it called? Yeah, a medical symposium on Parkinson's. That's usually in the summer. It's coming up in a few weeks. And then in the spring months, there's something that's perhaps a little bit less hard science. So those are the two main things that we do. And at least with the academic, with the medical programs, we usually get a couple hundred people. They're pretty popular. The other one, I'm not always involved with, and the more recent ones have occurred in the shadow of COVID, so they haven't been quite as popular as we would have liked, but they've worked as well. They've worked. So I think that's all I have to say. Does anybody have any questions about me, about Parkinson's? If you have Parkinson questions, I'm happy to answer them. Well, what I told Jessica as well when we were first talking about this is I said, in my experience, I could bring a topic, talk about it, and then people ask what they want to ask anyway, so why bring a topic? So, but I'm happy to answer any questions. Other than, I would prefer not to answer questions about specific things about you. So I don't want you to say like, oh, I'm on Mirapex and I want to go on Requip, what do you think? that type of thing. I can answer general questions, but I'd rather not answer specific things. So I'll just repeat the question just in case. The question was about exercise, about different types. Is one particularly better, boxing or Zumba or aerobics, or I think I forget what the middle one was. But the bottom line was a question about exercise. And I would say there's really, the key thing is doing something. The exercise we recommend is the one that you'll stick to. So if you like doing boxing, then that's a good one. But if you don't, then you shouldn't, and do something else. One reason we like the boxing is probably because it's good for your eye hand. It's good for feet as well. Most of the boxing classes, when you say it's contact, it's you contacting the bag. It's not somebody punching you. Right. I mean, unless they do it different here in Fresno, I don't know. But but the key is to do something. I think if you were going to say, should I do cardiovascular or weights? I think they're both important, but I think probably cardiovascular is a little more important. But again, just doing something is better than not doing anything. We often recommend slowly working yourself up until you get to at least 30 minutes a day, at least 5 days a week. Maybe you don't want to do boxing 5 days a week, so you do something else. Some people will like walk or jog if they don't have balance problems. They may do that. If that's fine, but we recommend, we don't want you stopping at every neighbor and taking 10 hours to do 1 mile. Right? We really want you to get your heart beating a little bit. But the exercise, in addition to keeping the body flexible, has been shown to probably slow the disease down at the brain level. There was a study where people were on tandem bikes, like bikes for two, and people got more out of that because they were sort of pushed harder because their partner, they have to pedal essentially to keep up with their partner. So we know that exercise is good, but we know that you have to challenge yourself a little bit. The other thing I'll mention is if you haven't been exercising, you're not training for the Olympics, don't sit down and go from nothing to, half an hour. You might only be able to do 5-10 minutes, and that's fine. You just got to slowly work yourself up. So the question was, why did I leave Las Vegas and why did I select Fresno? So I enjoyed Las Vegas, and it was good to me. We got a new dean at Roseman, and they kind of had different priorities. So I wasn't quite able to do everything I wanted to do, and my research coordinator left for a different job, and they weren't really hiring another one, so it kind of messed up my research. And then, so I started to look around, and I'm married, and so before I chose anything permanently, I figured family's going to stay in Las Vegas while I make sure wherever I go is a fit. And so we wanted to be somewhere relatively close to Las Vegas. My family's all in the East, but her family's in California and all. Plus, my wife hates the cold. I don't know that she likes the heat of Vegas or necessarily Fresno, but she wouldn't there's no way she would move to the Northeast, for instance. I don't think she could live anywhere where it snows. So that was part of it. So then I was using that as criteria as I was looking around. The Fresno opportunity presented itself, and there weren't any, but there weren't like a million movement disorder people. It seemed like a good opportunity for me, a good opportunity for patients. So I said, let's give it a try. It's a 45-minute flight to Vegas. So it's pretty easy to get back. Unfortunately, the mountains make it a little bit tougher to drive, but at least the flight is quick. So there you go. So the question was, what stuff, do you mean me specifically? Yeah. Question was, what stuff do I treat at the facility? So ideally, I'm not there yet, but ideally, I would be seeing all movement disorder patients, tremor patients, chorea patients, patients with abnormal movements that aren't seizures. So by far, any movement disorder doctor, just about, the majority of patients they see would be Parkinson's. Okay. Oh, yeah. So within Parkinson's, I do a little bit of Botox, like for drooling, although we don't have that set up yet. I don't do Botox for dystonia, but there are other people that do. But I do. I have a lot of experience with DBS. I doubt any of you have ever seen this, but I trained on DBS with Medtronic when the equipment was like a briefcase. You looked like a spy walking in. You can probably find that briefcase on eBay, but that'll be or in Minnesota in the home office they have one, which they actually had to buy on eBay for their museum because they didn't have any left. But yeah, I've been doing DBS for 21 years, I think, 22 years, something like that. So the question was essentially clarify where I am and the difference between me and Dr. Krell. So I'm rarely at the hospital, other than maybe the cafeteria. I'm rarely at the hospital, but my office is on, what's it on? It's on Fresno Street next to the Hyatt, for those of you who know where the Hyatt is, but it's across the street from Kaiser, thank you. It's across the street. I was going to say the big HMO. I couldn't think of the name. It's across the street from Kaiser. Patients have told me that if you don't know where you're going, it's a little tricky. But I will tell you the GPS. If you have GPS, it does get it right. But it's not immediately obvious driving past the building. I think they're still putting up signs and stuff. Anyway, so that's where I am. I don't see patients usually in the hospital. There's a downtown office which is attached to the community hospital, I believe. I don't see patients there. Just in the one across the street from Kaiser. So I know he spoke here. Some of you may have met Dr. Krell. So Dr. Krell is a neurosurgeon. I'm a neurologist, so I'm not operating on your brain, and God help you if you want me to. But Dr. Krell is a neurosurgeon. So just like if you have something wrong with your heart, you might take medicine from the cardiologist, or you might get a bypass from the surgeon. That's sort of the difference between us. And Dr. Krell is a fellowship-trained functional neurosurgeon. So for patients who have DBS or some other procedures, Dr. Krell is specifically trained in that. So he can do neurosurgical procedures just like any other neurosurgeon. I don't know that he does much on the spine, but he does other brain surgeries. But his specialty is functional neurosurgery. So if a patient is referred, if I see a patient and I think they should have deep brain stimulation surgery, DBS surgery, I'm going to refer them to Dr. Krell because not every neurosurgeon is trained in that technique. And he was trained in that at Stanford under a guy named Jamie Henderson, who's very well known. So well known that I, as a neurologist, know his name. That's how well known he is. Right. And if somebody thought I think I'm interested in DBS, interested in deep brain stimulation surgery, the first stop would probably be me, not him. And if a patient saw him first, even if he thought that they were the perfect, best candidate ever, he would still send that patient to me to sort of approve, if you will. The goal, obviously, with any surgery, the goal is an effective treatment. With DBS, the two important things: one, you need to have a surgeon who knows how to do it, that they're not going to, stick it through the eyeball, right? They're going to do it correctly, and that's Dr. Krell. But you also have to make sure that the patient is the right patient. If they're the wrong patient, the surgery could be technically correct, but they may not get the benefit that they're looking for, and that part's my responsibility. The question was, do I take care of Parkinson patients with non-motor symptoms? I take care of Parkinson's patients regardless of the symptoms, motor, non-motor. I think, not to pat myself on the back too much, but I think movement disorder trained neurologists like me, I think we tend to appreciate the non-motor symptoms more than the general neurologists. And we know that, as the disease progresses, it's typically the non-motor that's more disabling than the motor symptoms. So that's my long answer to say yes. So the question was about how much time will I be devoting to trials versus clinic patients versus normal care. So, you have to have the right ratio, right? If you do all trials, you don't have any patients to put in them. So the way I did it in Las Vegas is I essentially built to a day of trials, 2 half days of trials, and the rest, 1 half day of administrative time, and then 7 half days of patient care. And it may not even be that much at first. It may be a half a day for trials and then 8 half days for clinical care. But trials, the time that the patient is in for the trial visit is a very small percentage of how much effort you have to put in for that patient, especially the coordinator. The coordinator spends more time doing paperwork type stuff than spending time with the patient. I mean, there's a lot of bureaucracy in trials. So you need to have perhaps a little more time than would be expected, but it's going to be heavily weighted towards the clinic because I want to be able to get the patients. So that's a good. I was actually going to, when you asked that question, I was actually going to address that anyway. So the question was, how do I select patients for the trials? So there's 2.5 ways. So one thing is that once we have a trial, we go through the list of patients and we see, and I'm actually pretty good at remembering, like, oh, Mr. Smith, I think might qualify for this. So we go through and check, and we see, like, okay, for this particular trial, you have to have been diagnosed less than 3 years and you can't be on levodopa, whatever. And so we look, that might be an early trial. Or this one, you have to be on levodopa and be having fluctuations, dyskinesias, whatever. So we look to see who might qualify. So if they're already in the database and we see somebody, then the coordinator will call up the patient and say, hey, we're doing a trial where we think you might be a good candidate. Let me give you the 10,000-foot description. Is this something you think you might be interested in? If they hear the description and they think they're interested, we bring them in maybe for a visit if I'm not sure, or just for an information thing where we go over in more detail, including the consent process. So before you go into any trial, you'll have to sign a consent form. And a consent form is like 30 pages long. We want to make sure you know what's going on. And you're told everything, but I will go over the highlights. And so anyway, so we go over that. You don't have to sign the form right away. We then, let's say you sign the form, we then bring you back. Usually there's sort of a pre-trial visit as part of the trial to confirm that you meet the criteria. Sometimes there's going to be something in there that I didn't know about that keeps a person out. They meet all the criteria, but it turns out they had a history of prostate cancer, and any cancer disqualifies a person, and I didn't know that they had that. Sometimes there's something, so I check all the things, but sometimes there might be something that slips by. I had a trial in Vegas where I had the perfect patient for it, and I brought him in, and it turned out the age cutoff was 80, and he was 82. And it didn't even occur to me, because most of the patients, that's not an issue. I didn't even look. And I actually had that happen the other way, where I had a young onset guy who was too young for a trial. So of all the things, age is not something I routinely look at, and I've missed a couple of patients because of that. So anyway, so one way is that we go through the database. Second thing is that I see a new patient, and they come in and they see me, and I do everything, and I say, hey, we have a trial going on that I think you might be a candidate for. Is this something you're interested in? And again, I give them a little bit of an overview. If they think that they're interested, in Vegas, I would bring the coordinator into the room and have the coordinator talk to the patient, give them an overview of what being part of research is, what it involves, and we would give them the consent form to review, and if they were interested, we would bring them back. I said 2.5. The half part is sometimes another neurologist will say, I think I have somebody for one of your trials. So they'll send them over to me. We'll usually see them in one visit to decide if they're a candidate, if we're doing a trial and they're seeing another neurologist, they don't have to leave that other neurologist to be in my trial. They would have to see me as part of the trials, but otherwise they could continue to see their home neurologist if they would like. Let me talk a little bit. I have some more stuff to say about research, but does that sort of answer those questions before? Let me just say a little bit more about research in general. So I encourage patients to be part of research, and actually in my experience of all the disease states I've ever been part of, Parkinson patients are often the most receptive to being in research. I think they tend to be more well-read, either booklets or online, and just more engaged than some of the other disease states. With research trials, for the most part, there should not be any expenses to the patients, okay? So if somebody says to you, hey, have this research trial for stem cells, and it's gonna cost you a few $1,000s, it's not a research trial. They may be doing research, and I use that term lightly, but it's not really a trial if you're being charged. In all of my trials, there have been no charges for the patients for anything related to the trial. That includes oftentimes getting compensated for your fuel for your car, and maybe a little bit for your time. You're not going to go get rich off the clinical trial, but you're not going to lose money either. I don't think I ever had to do this in Vegas, but if I'm doing a clinical trial here and somebody comes up from, I don't really know the cities around here, but somebody drives a long way, the trials will often put you up in hotels if you're not local. And in terms of transportation, if you say, I'd love to go there, but my spouse is working, I have no way of getting there, the trials will often pay for cabs or Ubers to get you to the trial. So they're very good about this. In fact, probably not for any of the trials that I would be doing, but for some of the rarer disease states or rarer trials, sometimes the trials don't have as many sites and they'll pay for like airline transportation even. So my point is there should be no expenses. And just taking that a little bit further, knock on wood, this has never happened, and I don't think it'll happen with any Parkinson trials, but if you had something bad happen in the trial and had to be hospitalized for it, they would also pay for that. But again, I've never had that happen. So there shouldn't be any expenses. We work around your schedule. So in Vegas, I had a couple half days specifically set aside for clinical trial patients so that they wouldn't interfere with clinic patients. But I had patients who couldn't come on certain days, or sometimes there'd be some emergency and we'd have to bring them in on an off day. If you're interested in a trial that I'm doing and you say, I can only come Tuesday afternoons, even though the trial time is Thursday morning and you can only come Tuesday afternoon, we will see you Tuesday afternoon. We will work around your schedule as best we can. If you tell me you can only come Saturdays at 2 in the morning, I'm not going to put you in the trial. But otherwise, I will put you in the trial. I will do my best to work around your schedule. Some advantages of being in the trial, but I do not recommend going into a research trial for these things, but these are some fringe benefits to the trial. One is that even though it's not a clinic visit, it's a trial visit, we sort of roll it into one. So you can get extra visits, which may or may not be an advantage, I don't know. But there's no like co-pays or anything for those, so that's nice. Another fringe benefit that I ask that if you get this, that you don't abuse, if you're in a clinical trial, you'll have my cell phone in case there's an emergency. So most likely, I don't know, I wasn't on Epic there with my chart, maybe not, but you probably have my cell phone. So I've been involved in clinical trials for Parkinson's since about 2003, 4, somewhere about that. I usually try to have a few trials going once I'm up and going, and I try to have trials that don't compete with each other. So I don't have like 3 trials where you have to be newly diagnosed. I might have one for newly diagnosed people. I have one for maybe people having dyskinesia is a little bit more advanced, and maybe one in the middle. Clinical trials, we try to, even though we use the medicines for like everybody, from a trial point of view, we try to keep them clean so that it's easy to know if there's benefit or not. I also don't usually use trials where you have to come off of medicine, because I feel like if you're on medicine, why should I take you off of it? It's doing something. So there are some trials where they might say you need to come off your levodopa, for instance. Now, there might be a trial. I was doing a trial where for what ultimately became Rytary. For any of you who don't know, Rytary is a form of carbidopa levodopa that's both immediate release and extended release. And if you were in that trial, you came in on levodopa. In the trial, you were either on Rytary or carbidopa levodopa. Or generic carbidopa levodopa. You didn't know which one you were on, but you were definitely getting levodopa. So it wasn't like you were on levodopa or nothing. So you might come off your medicine, sort of, but you're still receiving it in the trial. I hope that wasn't too confusing. And the trials, usually the way the trials work, usually there's a period of time where you don't know if you're on the study medicine or not. That might be 2 months, 3 months. And then usually there's a time after that, 6 months, a year, maybe until the drug is approved, where you're on the drug, you get the drug for free, and you're on the drug, and it's to continue to observe people to see if any side effects appear. Another fringe benefit of trials, which is not a reason to do the trial, but another fringe benefit of the trial is that you get free drug. The question was, how will people know about the trials? I hope that we will have a link. I don't know the answer to that. One way you may know is you may get a call from us. Another thing, and this has nothing to do with me specifically, but if you go to the website clinicaltrials.gov, clinicaltrials.gov, just about any trial for any disease anywhere in the world is on that site. So, if you're sitting here in the audience as a caregiver and you have arthritis, you can look up arthritis on here and maybe find an arthritis trial, for instance. But obviously you can look up Parkinson's and have all the trials. So maybe I don't have any trials right now, but maybe there's a trial for just what ails you at UCSF or UCLA. I mean, obviously that requires a little bit of traveling, but, I encourage people for research. Another place where you can find trials specifically for Parkinson's, although I'm not sure that everything appears, is on the Michael J. Fox website. They have what they call the Fox Trial Finder. And I think the Fox Trial Finder, if you sign up for that, I think they ask you can give your information, and I think they will email you if you qualify for a trial that's new. So it may not have everything, but it may be a little bit more proactive for you. Okay, that's what I thought. So he's confirming, yeah, they register you if you want, and you can put your information in, and they'll contact you if they think there's a trial starting that you qualify for. I'm seeing patients already. Oh, yeah. So I brought some cards. The question was about, so I've been seeing patients. I'm in the office every day of the week. Sometimes on Fridays I'm not there because I'm flying back to Vegas, but generally speaking, I'm there every day of the week. I have cards. My cards haven't come in yet, so you'll see there's stickers. I don't know whose name is actually on these cards, but my name is over them. But all the information is correct. I don't know the process. I think, from my point of view, I don't care if you need a referral. I think the office requires them. I honestly don't know. Let me talk with some of the supervisors to see. Obviously, the goal is to make it easy for the staff. And from a neurosurgery point of view, you don't want people just making appointments. So I think that's where the referral thing comes in. But let me talk with them to see if there's any real reason why we need the referral or if it's just because of that. Yeah, I'll talk with them because I know when I was at Roseman, they wouldn't schedule people until they had their records. And for my partner, who dealt with a lot of things like neuropathy, nerve pain, back pain, he needed the records because he needed to see what they had done, what tests. But for movement disorders, I can see what's going on. And for the most part, I don't need records. So I talked to them and they stopped requiring records for mine. Let me do the same here to see if I'll talk with them next week to see if the referral is it may be a financial thing. If it's a financial thing, I can't get around it. But if it's just this is what we do thing, I may be able to get them to stop that. Okay, so the question was about Michael J. Fox and biomarkers. So for those who are not aware, there's a big study. It's ongoing. I don't think they're recruiting anymore, but it's called the PPMI study. It stands for, I don't know what the second P is, but it's Parkinson's Marker Initiative. Primary, I don't know. There's two Ps, but I don't know what one of them is. But anyway, the idea is what they're doing is they're seeing patients as well as first-degree family members and also people who don't have Parkinson's, and they're seeing them over about a 5-year period. They're getting lots of blood work, lots of urine work, and I think some, not everybody, are getting serial spinal taps as well. And they're being treated by their clinical neurologist. But the study, there's no medications as part of the study. And what they're trying to do is they're trying to see, as I'm sure you're all aware, there's really no blood test for Parkinson's. We have things like the DAT scan, which look at dopamine in the brain. There's that skin test, which personally I don't think is quite ready for prime time, but there's the skin test out of Phoenix. But we don't have any really easy ways to diagnose Parkinson's, just, like we do with cholesterol, for instance. But the bigger issue is this. The reason that they're doing that study is the feeling is that most of the way we have medicines now help symptoms, but it doesn't necessarily change the course of the disease. And we'd like to have a way to bend the arc, to slow the disease down, to certainly to cure the disease, but if not cure, to markedly slow. And we know from a lot of studies, like the studies for stem cells, for instance, we know that people who get them earlier do better because they still have a nervous system intact to save versus getting it later. Now, with stem cells, the idea is, why would you do something so dramatic if all they have is like tremor in their pinky? But that's the theory. So the idea of the PPMI is to see if there's some marker in the blood that we could do to say, hey, this person isn't showing it yet, but they're going to get Parkinson's in a year. So let's give them this to prevent the Parkinson's from coming. Or instead of getting it in a year, they'll get it in 10 years. So the idea would be to delay it. It also, if we find a marker, it will also make the cost of drug trials much less expensive. Because right now, we do a lot of clinical stuff, which is good, but it's a little clunky, and you need a lot more people to show statistical significance. If you have a lab, you don't need quite as many people. You can get drug trials done quicker and medicines to the market much quicker. So I think the PPMI thing is very good. My hope is that they find something, even if it is ultimately negative in finding something, there's a lot of research that's come out of it. So I think in general, it's a good thing. It's an enormous study. It's sponsored pretty much by the NIH and every drug company. It's very all-encompassing. Well, so again, it will probably mostly be used for diagnosis, but also, again, for drug trials, if you're doing blood pressure trials, I can give you an exact number, right? I can say, oh, your blood pressure was 140/90, and now it's 120/80. It's very, very discrete. Whereas if I'm doing a Parkinson trial, I have to do the UPDRS, which is like 30 questions where you got to rate the patient 0 to 5. And when I rate a 3, this person rates a 4, and that person rates a 2. And so it's a little gray. It's a little fuzzy. It would be nice to have something where we could say, the extreme example would be, if you have this, you have Parkinson's. Okay, we gave you a medicine. Oh, look, it's gone. He's not going to get Parkinson's. I don't think we're going to be quite there, but it gives you the extreme example. Yeah, that's correct. The question was, if you have weakness or pain in the joints, is that or is it not Parkinson's? And it's usually not Parkinson's. You can get pain from Parkinson's. You can get weakness. The weakness I think of as more like muscle inefficiency, either from atrophy or just because of the disease, you have to use more muscles to do what you used to do, which can be fatiguing. You can also have pain as part of Parkinson's. It's usually an off symptom, but not always. I would argue that if you can point like, oh, the pain is right there in the elbow, that's probably not Parkinson's. If it's more diffuse, more vague, that's typically more how the Parkinson's pain presents. Just one other thing I realized when I asked you that question, one other thing I'll mention about research, the number of visits, a lot of times when you start, it might be like you come now, you come in 2 weeks, you come 2 weeks after that, but then it's like after a month, maybe another month, and they start to spread out. In the beginning, it's a few visits, but I don't want you to think it's every day or even every week for a long period of time. She asked what the visits consist of, and it's really variable. It depends on the study. Sometimes the visit might just be, you might not even see me for more than a couple seconds, and you're mostly just getting blood drawn and a urine and maybe answering a survey, a quality of life survey. Other times, I might be doing a really comprehensive exam on you, and there might be a few things, so it might be a half-hour visit. During most visits, if it's a study medicine, they're going to have you bring in your pill bottles and count pills. They might give you new bottles, take the old ones. So sometimes that can take a little bit of time. That's with the coordinator. That's not with me, but it's really variable. The question was, will I get a coordinator? Do you know one? Yeah, so that's one of the obstacles right now. I think they had one who unfortunately left in April. So I think they're trying to get one. One of the surgeons, so where I am, we have neurosurgery and neurology. And one of the surgeons there, Dr. McDonald, I think he's in charge of research for all of community, at least in Fresno. And that's like his big challenge right now. I mean, and he wants to do trials, not Parkinson trials. He wants to do trials like surgical trials that involve like the ICU and the hospital. Those are much tougher trials to pull off. The trials that I do are pretty easy, but I need a coordinator because there's just so much paperwork to do. So the question was about taking people off medicine. So that can be answered two ways. So let me answer both of them. So if, for instance, like the Rytari trial, if you're on levodopa, which you had to be to get into this trial, you might be taken off of the levodopa that you were on, but you're still going to be put on, for instance, Rytari, which has levodopa in it, and most of these levodopa trials, you can take regular carbidopa-levodopa as needed as well. But I'm not going to do a trial that's like, let's say I'm doing a trial that to get in the trial, you can't be on carbidopa-levodopa. I'm going to put people in that trial who are newly diagnosed, but I'm not going to put somebody in that trial and say, stop your levodopa so I can put you in that trial. I will tell you, though, that most Parkinson trials, you are allowed to treat the patient. We try not to make medication changes, but the goal isn't to torture the patient. So the idea is you go into the trial, your medicines are supposed to be stable the way they are. But if the trial is 2 years long, things might change with you. So just because you're on levodopa, you're not on levodopa now, maybe in a year, you need to be on levodopa. I'm not going to not put you on it because you're in the trial. The goal is to treat the patients, not to treat the trial. There are certain trials where going on levodopa is an endpoint, meaning if you go on levodopa, that's the end of the trial for you. I mean, you're still sort of in the trial, but maybe that's the end of the trial medicine. But again, but that's something we're trying to learn about as part of the trial. And if you need levodopa, you need levodopa. And just to let you know, I'm stressing levodopa because it's the one that comes to mind. But I've done trials, again, early trials for new medicines. We've done trials for some of the non-motor things as well. We did one for apathy in Parkinson's, using a medicine which unfortunately didn't work. But for instance, that. And there have been some, I'm not sure if it's still going. It's a difficult trial to recruit for because of different reasons. But USC had as well as other places, had a drug for constipation in Parkinson's. Constipation is very common. Now, I think it was a shot, and there were some other things. They told me it was a very difficult trial. They were having trouble recruiting. I was involved in a trial for hallucinations in Parkinson's. So the only, what I thought you were getting at was vitamin B6. If you're on levodopa, vitamin B6 can reduce the effect. Oh, can everybody still hear me? Sorry about that. Vitamin B6 can interfere with the absorption of levodopa. It's not dangerous, but it would lower the effect of the cinnamon, of the carbidopa levodopa. So if you're on levodopa, I often tell people not to take B6. But I'm not familiar with B1. So the question was about essential tremor in Parkinson's. I would argue with your premise just a little bit, but then I'll answer your question too. So the two most common things I see are essential tremor and Parkinson's. And while people shake in both, they are distinctly different. There is one family in Iowa that has a particular gene where if it goes one way, they get Parkinson's and the other way, essential tremor. Outside of that family, I would say they're generally very different. And so in Parkinson's, the tremor is a resting tremor, meaning when you don't use your muscles, you shake. In essential tremor, it's more of what we call an action tremor. When you use your muscles, you shake. So I have to stand up to show this, so I don't know if you'll be able to hear me on the mic, but I'll do my best. So if you're sitting down, put your hands on your lap, and I distract the person. I tell them to close their eyes, tell me the months backwards. In Parkinson's, usually one of the hands will shake because you're not using your hands, they're resting, and I'm distracting you so you don't even think about it. Conversely, the central tremor won't shake there, but if they put their hands up like this, they start to shake because they're using their muscles. Now, there can be overflow, meaning with Parkinson's, you could shake up here and a central tremor there, but it's where is the majority of the tremor. And so central tremor is an action tremor, Parkinson's is a resting tremor. But there are other things that differentiate Parkinson's from other things. Even though tremor is usually what gets the patient through the door, what we tend to think of as the biggest symptom of Parkinson's is slowness. There can be reduced facial expression, reduced arm swing when walking, and just a general slowness of thinking, of moving, of talking. Even constipation, you might think slowness of the intestines. Slowness is the biggest thing. There can be stiffness. It's not the same type of stiffness that you get with arthritis, but when I move the patient's arm, it almost feels like a cogwheel, like one of those things you see, I don't know, for water power or whatever. Anyway, it's got cogs, or almost like or sometimes it's like a pocket knife where it takes a little while to open it and then it opens. You get that stiffness. Those are all the cardinal motor symptoms, but then there are the non-motor symptoms. A big one in a lot of people is loss or reduced sense of smell. Patients don't always notice it, but a lot of patients do. Depression is very common in Parkinson's, although depression in and of itself does not mean that you have Parkinson's, but very common. Constipation, at the Mayo Clinic, they've documented patients with constipation as early as, I think, 20 years, 15 years before diagnosis. So constipation, very common. REM sleep behavior disorder. So normally when you're dreaming, when you're sleeping and you're dreaming, you're paralyzed except for your eyes and your breathing. In REM sleep behavior disorder, you lose that paralysis and you might kick, punch, yell. Usually it's the bed partner who complains, not the patient, because the patient's asleep and the bed partner is getting beaten up at night. So all of these things, so these non-motor symptoms that I just mentioned, and there's more to it than just those, but these non-motor symptoms I just mentioned, while not diagnostic, are often seen. The question was fatigue. Yeah, fatigue is very common in Parkinson's. Parkinson's is a very fatiguing disease, probably Some of it's the muscle inefficiency. Some of it, you got to do more to do stuff. Some of it's just the disease itself. Some of the medicines can contribute. When you do surveys of patients about non-motor symptoms, fatigue is often overwhelmingly the one that patients complain about. Yeah, voice is another one. The voice is often softer. I recommend when patients are home that if they're reading a newspaper, a magazine, their phone, whatever, I recommend reading out loud. Remember that to yourself, you sound up here, but to other people, you're down here. So you need to really project. There is speech therapy for Parkinson's. There's something specifically called LSVT, Lee Silverman Voice Technique, and there are 2 people in Fresno who are certified in this. But just doing speech exercises is helpful. There's something called Speech 5, which is not readily available. It might be if you go through the VA, but I don't think it's readily available. But it's a Bluetooth thing. Looks like a Bluetooth earpiece from your phone. So, and what it does is this. If you've ever been, say, on an airplane with somebody and you're watching a movie, and the person leans over to you and whispers, "Hey, what time does the plane land?" And you're watching your movie and you say, "It lands at 8 o'clock," because you're speaking like over your movie and you don't realize how loud. Sorry about that. That's called the Lombard effect. And all animals do it. If you hear birds and they seem to like progressively chirp louder to over each other, and dolphins do it, that's called the Lombard effect. So what this earpiece does is it sort of knows when you're talking, and it puts white noise into your ear so that you'll naturally speak louder. It's kind of ingenious. It was devised by a speech therapist from Purdue University. I'm not sure that they're on any insurance panels, and it's like $1,000 to get the device, except through the VA. But it may not even be available at the VA anymore. I'm not sure. I should contact the company and find out. But it's an interesting thing. I did try getting it for some patients in Vegas and was unsuccessful, but maybe I'll get more success. But I may have an app. I may have to re-download it. But I have an app on my phone with something that sort of simulates it to see if you would be a good candidate. So Jamila said she spoke to somebody, and it does have Medicare approval. One of the national sales guys from the company was with Medtronic for a long time. I've known him for a long time, so I'm going to call him and find out, is it actually gettable? So there may be a manufacturing issue as well. So questions about vibration therapy. So Charcot, who was a famous French neurologist who named the disease Parkinson's disease after James Parkinson, and who had many famous students like Charcot's the neurologist, like Tourette from Tourette syndrome. Tourette was one of his patients. He's like essentially certainly the father of European neurology, and maybe the father of all clinical neurology. He felt that vibration therapy might be helpful, like people riding in carriages. Remember, there were no cars, right? Carriages that were like bouncing all over the places. He felt like his patients did better, and he sort of devised this chair to shake patients. There's a neurologist out of Chicago who's a big Charcot-ophile, and he speaks French, and he went to Paris and read Charcot's notes, and he's trying to recreate this and to do a trial to see if it would be helpful. I don't think we have more data than that at this point. So stay tuned. I was waiting for somebody to ask that. So the question was about stem cells, any advances. So stem cells are a pretty controversial thing. I sort of hinted at this before. So for those of you who don't know, stem cells are cells in the brain that are not, that have not yet matured. Not differentiated is the word, that's right. Not differentiated, not matured, and they can grow into any cells. So the premise would be the cells in the brain that are producing dopamine are dying, let's inject stem cells and have them grow back. So that's the premise. There was a trial done in the early 90s, if you can believe it, at Columbia University in stem cells, which showed some benefit. It tended to preferentially benefit younger people versus older people, but it did show some benefit. There were some problems, but there was benefit. But there are a bunch of problems. The first is, even if you had a cup of stem cells here, it's tough to get those stem cells from the cup to the brain. You can't just drink them. You actually have to have the cells essentially neurosurgically implanted. And the neurosurgery is not, even as neurosurgeries go, it's not a quick surgery. So it's a little bit more involved. So, there's that thing. The second thing is that we know that Parkinson's is more than just dopamine. Dopamine's a big part of it, but it's more than just dopamine. So even if you're able to grow back the dopamine cells, are you going to cure the disease? Probably not. In the trial in the 90s, in some of the people, the stem cells worked too well, meaning they turned on and they kept going and going and going. And they had what we call runaway dyskinesias. They had bad dyskinesias from too much levodopa and needed DBS, deep brain stimulation surgery. The last thing, maybe not the last thing, but the next thing I'll mention is that what's been shown is that after having Parkinson's for 1 year, the nervous system in Parkinson's is really dysregulated. And stem cells would be most helpful in somebody whose nervous system is not dysregulated. It has more to grow. But the problem is right now, if I see somebody with tremor in one finger and I diagnose them with Parkinson's, I don't know if they're going to be, in 10 years, it's going to be 2 fingers, or in 10 years, are they going to have it all over and need DBS or more stuff? I don't know how they're going to progress. And so what would make sense for stem cells is to do the surgery in that first year. But I don't think it's worth the risk of the brain surgery for that one finger if they're just going to be very mild. Now, if we had a way of knowing, are they going to progress like this, then you'd say, oh, they're going to progress like this. Let's do the stem cells in that person and see if we can change the curve. But we don't know that. The last thing I'll mention about stem cells is that there's a lot of people who promote stem cells for a lot of things. I already told you it's tough to get stem cells to the brain. So some people inject it into the spine. And there was an article in the New York Times about a guy who went, I think, to Mexico, had stem cells injected into the spine, and he ended up getting tumors on his spine. So there's a lot. I would not recommend stem cells to anybody that's not part of a clinical trial. And if it's not, and it's part of a clinical trial if you don't have to pay anything. So if it's part of a clinical trial and they're not paying anything, it's probably legitimate. It's probably at a university, probably legitimate. If you hear the stuff and you're interested, I'm all for it. It's, being under good supervision, and I think it's reasonable. I had a patient, one of my first patients in Vegas, actually, who was in this, I don't think he knew this person, but he was in the supermarket and ran into somebody, and they each recognized that they had Parkinson's, and they were talking. And he came to me and he said, this guy went to Mexico, paid $10,000 for stem cells. What do you think of that? And I said, I'll tell you what, if you give me $5,000, not $10,000, $5,000, so a bargain, you give me $5,000 for stem cells, I promise you that one of us will be very happy. So he didn't give me the money. But anyway, I spend a little bit of time on this because, unfortunately, I think, these people prey on people who are desperate. And and you can go to Mexico or whatever and do this. But I think there are people in like San Diego that I've seen advertised in the Las Vegas papers about stem cells. Again, it's sort of a broad ad, like, come for whatever ails you. And, I think they use stem cells for certain things. I think like cartilage type things. I don't really know. But But I do know in Parkinson's, it's not a treatment to be taken lightly. Yeah, so to answer your first question, I'm not saying it's not good for him or it is. I'm saying if you go for stem cells, it should be part of a clinical trial. And if he meets the criteria, that's good. If the criteria is, hey, we're doing it in early people, then he doesn't meet it. But I would not do it under any other circumstances. I steered clear of, so there are ethical controversies about stem cells. Sometimes they get them from, aborted fetuses and others, not, many stem cells are not from there, but some are. And there are ethical concerns. There may be religious concerns. I sort of don't touch on that because I feel like that's sort of an individual thing. And I just try to talk about the medical benefit and risk. And if that's an issue to a person, they need to take that into account. But from a medical perspective, from a treatment perspective as to whether or not it will be helpful, I don't find it related to that question. So I don't talk about that part too much. Does that? I'm not trying to make light of it, but it's just I don't think it's a medical answer. Well, there's research in that about using autologous, your own stem cells. I honestly don't know too much about that. Yeah. So the sort of closely related to stem cells is gene therapy. So what about stimulating the genes that stimulate nerve growth, like nerve growth factor? And that's where a lot of research has been. It's a little bit easier than stem cells to devise. It's not cheap, but it's cheaper than stem cells. And there's GDNF, BDNF. DNF stands for derived nerve growth factor, and the other letters stand for different things. And the idea is maybe we can turn these on, which will release nerve growth factor and stimulate nerve growth. I think some of these still require neurosurgical interventions, but I don't think all of them do. You bypass the ethical concerns that I was just briefly touching on because there's no stem cell stuff, so that makes people a lot happier. As expensive as they are, they're probably cheaper than stem cell therapies. It's probably a little easier to scale up, meaning if it proves successful, it's probably a little easier to commercialize than to commercialize stem cells. I will tell you that we're not there in Parkinson's, but we're slowly entering the age of pharmacogenomics, which is sort of specific genetic treatments for diseases, in this case, Parkinson's. And if you think insurance companies don't want to pay for medicine now, you ain't seen nothing yet, as they say, because pharmacogenomics is going to be extremely, extremely expensive. One of the gene therapies that's available for spinal muscular atrophy, which is similar to ALS, except it hits kids, like babies. If you qualify for this drug, it's about $500,000 to $1 million a year. Now, you don't have to take it forever and ever, but you have to take it for a few years. So, gives you an idea. I don't know what's going to happen. Well, yeah, so a big part of drugging, the question was, why are drugs so expensive? So a big part of it is research. You got to remember that, I don't know what the exact numbers are, but like they research 100 compounds. 20 of them appear to be suitable. They do trials. 10 of them appear to be safe in humans. 3 of them, they're able to do phase 3 clinical trials and maybe one of them comes to market. So it's like there's a huge funnel there. And my numbers may not be exactly right, but it gives you an idea. So they do try to recover the costs of that research. However, it's not all that. Supply and demand is reversed in medicine. So in multiple sclerosis, for a long time there were 4 drugs, and they were about 10 to 20,000 bucks a year. Not cheap, but not where I'm going. So then what happened was another drug came out that was more expensive. So drug came out was like $30,000. And these drugs that were 20,000 increased their price to 25 because this one was 30. And then ones that came out are 60, and these drugs that were 20 are now like $50,000. So as more drugs come out in MS, the price of the drugs have gone up, not down. So MS may be a little bit unique in the way that the drugs are and the type of disease it is, but and the fact that the way the drugs are, it's not easy to make generics of them, but unfortunately that's the case. Now, Parkinson's, some of the drugs like Rytary can be pricey. Let's see, what else? Ongentys is potentially pricey, but a lot of the Parkinson drugs are not expensive. I mean, they're certainly not thousands of dollars. They might not even be hundreds of dollars. Even apomorphine, Apokyn, which is the injectable, for most patients, I mean, if you look it up, it's going to say $1,000 a month. But for most patients, they're paying $50 a month for it. So fortunately, most of the Parkinson medicines are not too bad. Rytary is going to go generic, I think, next year or 2025. So that should bring it down. But the MS drugs, like I said, it's gone in reverse. The prices have gone up as more drugs have come out. Where are the most cases of Parkinson's located? I don't particularly know the answer to that. I think I know where you might be leading, but I don't know the answer to that. I will tell you, in general, we tell people it's 1% of all adults, 2% of all adults older than 65. I will tell you that there is an increased risk in areas with a lot of farming. So my understanding is there's a lot of farming in the Fresno area. No, I'm just kidding. I know that there is. If you're, essentially, if you have a lot of exposure, like breathing in fertilizers and stuff, depending on which one it is, there is an increased risk. I don't know, though, I don't know for certain that the prevalence in Fresno is any more than it is in Los Angeles or whatever. But certainly there would be reason to think it might be higher in this area of California. But what'd you say? What's pretty bad? Oh, air. Well, pollution in and of itself may increase the risk, but keep in mind that James Parkinson described the disease before the Industrial Revolution. If you read Shakespeare, there are certain characters, obviously he doesn't call it Parkinson's disease, but his description would suggest Parkinson's disease. If you look at Indian medical texts from like 2,000 years ago, there's cases that are probably Parkinson's. So Parkinson's has been around a long time. It's just, more characterized in the last 200 years. So I will tell you one question that I always get asked. I even got asked by my parents one time, and nobody asked it, and I couldn't believe it. Do you know what it is? Yes. Nobody asked me about marijuana or cannabis, and that's usually the question I get a lot on. Like I say, my parents asked me about that. So I will just tell you, let me ask you, I can't remember, is marijuana legal recreationally or just medically in California? I see. So yeah, in Nevada, it's approved both recreationally and medically. Actually, I'm not sure if it's actually approved medically, but it's approved recreationally. But I will tell you, there have not been a lot of studies with marijuana and Parkinson's. And the studies that we have are all over the place. What looks to be is it looks like it might help with pain a little bit, maybe with hallucinations, oddly enough. And that's what the research would show. It does not appear to help with the tremors. I've had patients in Vegas who said they take it, it helps them with their sleep. Okay. I was very happy when it was approved recreationally because then I didn't have to write. So it was never approved medically, but you could write it on a prescription. It would it was not quite, but kind of like a get out of jail free card for them, but not quite. But once it became approved recreation, they'd say, look, we have no evidence, but if you want it, there are 64 dispensaries in Las Vegas, go to one of them. So, but I don't recommend it. I recommend not spending your money on it at this time because we don't have enough evidence to support it. So I'm a little bit bad with this as well. You may know this better than I do, but I think CBD does not have THC in it. And THC is the psychoactive part of marijuana, the part that gets you high. So, so the other issue, but that reminds me, the other issue is, with CBD, for instance, but we don't know, like, for marijuana, cannabis, CBD with Parkinson's, we don't know, should you smoke it, eat it, drink it, take it in drops, wear a patch, cream. There's a million ways. I've never been in any of the dispensaries, but the dispensaries in Las Vegas have like a million different varieties, and we don't know which variety either. So, it's certainly not a slam dunk, right? If it were a slam dunk, we would know because there are enough people using it that we would know. So what I always would tell people when they would ask me is I would say, it's probably not cheap. Save your money and use that money and go on a cruise. And if you don't like cruises, save your money and use that money to send me on a cruise. Yeah, so the question was about the non-motor and which are treatable and about seeing a movement disorder person. So, obviously it's self-serving for me to say see a movement disorder person. I do recommend it if you don't live close. I mean, presumably everybody here is in Fresno, and like I said, my office is 20 minutes from here. But if you're coming from Bakersfield and you're, I don't know how far that is, 2 hours away. Maybe you have a neurologist who's 20 minutes from you. It still might be worth seeing that person most of the time and seeing a movement disorder person once a year or twice a year in addition, just to have some ideas. As far as the non-motor stuff, some of the non-motor stuff we sort of treat how we would treat anybody else. Depression, I use the antidepressants, the same antidepressants that you get put on if you go to a psychiatrist for depression without Parkinson's. But there are, like, with orthostatic hypotension, neurogenic orthostatic hypertension, and I was in that trial too, there is a medicine specifically approved, Northera, which is specifically approved for that. There are some other things we use as well, and some other things we look for. So I do think that, we tend to look for that more, and I probably have more experience prescribing Northera than a non-movement disorder neurologist. Sometimes, even if it's from the Parkinson's, I may send you to a specialist. So there can be sometimes urinary issues with Parkinson's. It's a little difficult to treat, and it can be difficult to sort out. And in particular, in older men, I got to make sure it's not the prostate before I assume it's the Parkinson's. So if somebody comes in with urinary issues, I'm going to send them to the urologist because I want to make sure it's not prostate or something else. Sometimes I may even rely on the urologist to treat them because I don't write a lot of the overactive bladder medicines, for instance. And there are a few. I think there are definitely some in San Diego because there were none in Vegas, and I would send them to San Diego. There are actually neurourologists. Talk about your subspecialty. So sometimes I send people to there. Sometimes people have eye issues, double vision, for instance. I might send you to the neuro-ophthalmologist for evaluation of that. There's not a lot I can do for that. Constipation, I often recommend different things. There might be some things I can do. If we're not successful, I might send you to a dietitian, but I might also send you to GI. So even though I think Parkinson's is the cause, or primarily the cause, I sometimes use the other specialties to help with treatment. So for hallucinations in Parkinson's and depression, typically I feel comfortable treating them at least at first. Now, if the depression, for instance, is really profound, if they have like catatonic depression as part of their Parkinson's, I'm going to send you to a psychiatrist. You probably need ECT, for instance, and obviously I'm not going to write that. Maybe I've seen the person, I put them on whatever, sertraline and bupropion. You're taking both of them, and the depression is still your biggest complaint. Maybe the Parkinson's is relatively well controlled, but the depression is just overwhelming. At that point, I'm going to send you to the psychiatrist. If the patient is in the office and not only are they depressed, but they're like really tearful, or maybe they've had suicidal thoughts or something like that, I'm probably going to send you to a psychiatrist. There are certain times I'm not going to mess around. The hallucinations, there are a few things that I would do if the patient is still hallucinating, particularly if it's really bad. I had a patient, and there's a term, it's called Capgras syndrome, C-A-P-G-R-A-S. It's one word, it's a name. Capgras syndrome, where you think people where your loved ones have been replaced by identical duplicates. It's really strange. It's hard to conceive. I had a patient in the office who I had on like maximal doses of hallucination medicines that I thought were really good. She was still seeing like her house on fire. She said to me, "Can you believe that this guy over here looks so much like my husband?" I mean, I read about it before. I had sort of seen it. I had never seen it so floored as her. I sent her to a psychiatrist. I didn't know what else to do. Most patients with hallucinations in Parkinson's, most of the time they're visual. Most of the time they're people or animals, and they're not scary, but but sometimes it can be a little unnerving, especially if the patient does not have insight. They might wonder why these little kids running in my yard all the time. The medicines often work pretty well, maybe not 100%, but like 80%. And so I feel pretty confident, at least starting the treatment with that. I don't routinely send people straight to psychiatry. And of course, I'm new to Fresno, so I don't know who to refer to anyway at this point. So it takes a little bit, it's going to take me a little bit longer to figure that stuff out. It could be. And if the question was about foot dragging, it could be, hey, you guys aren't allowed to leave, just so you know. No, just kidding. But the foot drag can be part of Parkinson's. I would say that when we're treating the patient, we're trying to treat how they are most of the time. So if they have a foot drag one day a month, I don't know that we're going to be too aggressive at that. On the other hand, if they're foot dragging every single time they walk, obviously I want to try to treat that. The question was, can you tell if the hallucinations are coming from the disease or the medicine? So I will tell you that, Nuplazid is the drug that's FDA approved for hallucinations in Parkinson's. In the clinical trial for Nuplazid, there were, I think, 3 or 4 patients who were on no Parkinson medicines and still had hallucinations. So the disease itself can cause them. Certainly the medicines can cause them as well. And the medicine that's the biggest culprit in causing them are the dopamine agonists, the dopamine imposters, which are pramipexole, ropinirole, and rotigotine, which is the patch. So if somebody is having hallucinations, and let's say they're only on pramipexole, they're not on any other medicines, I would take them off the pramipexole, and they probably need to be on something else. I put them on levodopa. But if they're on other stuff, if they're on levodopa and hallucinating, usually you can't take them off the levodopa. So we just wouldn't know. But if they're on the agonist, I do try to take them off of that. So the question was about testing, like for the genes for Parkinson's. So let me back up a second and then I'll answer your question. So I will tell you that in general, for most people, I would not recommend gene testing. There are some gene tests that can be done, but most people probably don't have them. And we treat people the same way. So I would not recommend just doing the gene testing. If you're in a research trial, they may do some gene tests on you, but I would not recommend it because I feel like all you're going to do is potentially make yourself uninsurable or less insurable. As far as, let's say you do know you have a gene, should a child be tested? I would still say no for a couple of reasons. One, many of the genes in Parkinson's are recessive, meaning even if the patient gets it, they're not going to show it. But even if it's a dominant one, which is they're going to have it, it doesn't tell us when. And that non-insurable stuff, even though there's theoretically a law passed to prevent it, I think you're going to make that person less insurable. We don't know when they're going to get it. And even if I knew that that person was going to get it in 20 years, I have nothing to give them now to stop that. Where this comes up more often is Huntington's disease. Huntington's disease, anybody that has the gene is going to get the disease, and the disease will probably kill them in 7 years, 10 years, something like that. But we still don't recommend doing it unless it's going to affect your life. Like if you say, I'm thinking about going to medical school, but if I have this gene, I'm not going to go to medical school because I don't know how long we're going to, when am I going to get symptomatic? And then I only have 7 years after. So, some people check to see if they have the gene before having kids, that type of thing. But Parkinson's, even if they have it, we can treat them. So I would not recommend anybody get the genetic testing unless there's a clinical trial for family members of Parkinson's. The question was, is there data saying how many people have it? My guess is that there is. I don't know what it is. There are a lot of genes that can potentially give Parkinson's. There are only a handful that we can test, and most people do not have the ones that we can test. One thing that is a little bit more common is that there are some association genes, meaning if you have them, you're at a higher risk of getting Parkinson's, but it's not a yes or no thing. It's not not like eye color. The example I would give is if you have the association gene for gambling addiction and you live in Las Vegas, you're in trouble. And if you live in Saudi Arabia, nobody ever knows. It's that type of thing. Just because I say if are there any more questions, there don't have to be. But remember, my family's in Vegas, so I can go until Monday morning.
Welcome to Fresno.
Thanks, thank you.